Our next speaker, a big welcome to Daren Edwards from Barts Health, who's going to do a session on managing skin grafts and donor sites.
This is working. Can you hear me? This is working now.
Yeah.
Is it working?
Yes.
You can hear me, right? Okay. Well done, Fran. Well, hard act to follow, I think. I just want to say thank you for inviting myself and Chrissy to come along and give you a story really from the burns and plastics side of things. I think the concurrent theme this morning is thinking outside of the box. And we certainly do that in burns and plastic surgery. Okay, I've been asked to come along and give you a talk about managing skin grafts and donor sites. Just as a quick straw poll, how many of you dealt with skin grafts and donor sites in the past? Quite a few of you. Okay, good. Right. I thought what we'd do first of all is just give you a very brief history of plastic surgery. Plastic surgery has been around the block a few times in the last few thousand years. We know from ancient texts in India that there's been nasal reconstructions carried on for those people who had their noses cut off as some sort of judicial punishment. In 1442, Brancus in Italy described successfully transplanting the nose of a slave to his master from his arm. I want to see that. And in 1944, the American Webster was using refrigerated skin as a temporary dressing following burn injuries. Unfortunately, plastic surgery seems to be one of those specialities that goes in leaps and bounds when it comes to wars and conflicts. And if most people tend to think that burns and plastic surgery is, nose faces, boob jobs, tummy tucks, those kind of things, it's nothing like that at all. Nothing at all. We also in the United Kingdom had the Guinea Pig Club in the Second World War when Battle of Britain pilots were crashing their aircraft and getting severe burn injuries. Archibald Mackindoe was treating these pilots and starting up some really, really good bits of early stages of microvascular surgery. And that's really advanced since the 1960s. So a quick anatomy and physiology lesson. When we're talking about skin grafts, a split skin graft really is coming from the top of the epidermal layer, part of the dermis, and a full thickness skin graft really takes from the epidermal layer right down to the epidermis itself. And there is a difference between a split skin graft and a full thickness graft. And there's approximately 2 meters of skin on the average adult male in this country. And if you're working out in terms of percentage of your body, if you put your hand up like that and close your hand, that's 1% of my body surface. So when you're looking at wounds, particularly in plastics and burns, we would be looking over and measuring a wound by the percentage of its total body surface area rather than trying 15 centimetres by 2 centimetres by those kind of things. So we tend to look at a burn or a skin loss, burns, you're talking about burns, isn't it, as a percentage of body loss. Why do we skin graft? Looking at some of the pictures that Fran showed earlier on, we would skin graft some of those wounds. And the reason why we do it, it's the most rapid and it's the most effective way of covering a wound that's either usually difficult or impossible to cover themselves, either through lack of time or because they can't be closed directly. And following on, really, we don't have the luxury at the Royal London of keeping people in hospital. We simply don't. We are a level 1 trauma centre. We specialise in virtually every speciality going. And we can't and don't have the time to keep people in hospital with what can be complex or chronic wounds. We just don't have that time. And sometimes skin grafting is a much easier and quicker way. And sometimes from a cosmetic point of view, when a wound is healed, you can get hypertrophic scarring, you can get keloid scarring. It is less likely with a skin graft that you would get those issues. So for us, we would try and skin graft as quickly as possible. By doing so, you're cutting down on risks of infection, although you are creating one wound to cover over another wound, which is usually your donor sites. Donor site selection. We can take skin from anywhere. Usually the most common aspects are the thighs, buttocks, back, arm, abdomen. In fact, really anywhere where there is skin, we will take it if need be. And particularly in severe lower limb trauma or degloving injuries, we would tend to use an abdomen or a back or the other limb if need be to cover that area. In some traumatic injuries, particularly a lot of lower limb trauma injuries where we share a lot of the wounds with the trauma and orthopaedic teams, and those have external fixators on their wounds, we tend to take the skin from the same limb. So therefore only one limb is affected, the other limb is spare. So therefore when it comes to mobility issues, only one limb is affected, and therefore it does make life a little bit easier. Full thickness grafts, these are the ones that take the epidermal and dermal layers. They can be pre or post-auricular, supraclavicular, in the groin, scalp or the eyelid, and these are directly closed, usually closed by sutures and left to heal by their own intentions. Split skin grafts obviously take about 10 to 20 days to heal depending on the patient themselves, depending on circumstances. Some of the terms that you might hear, the most common one is an autograft, and that's skin from you to you. Skin taken from one individual to another is termed an allograft, and that usually, and we do use allografts, these are usually cadaveric skin. We can use porcine skin. It's a lot cheaper than allografts. And there are some times when we have to use these because patients are too sick to actually go to theatre and actually have skin grafting carried out. So sometimes it's easier just to clean the wound up and then to put an allograft or a porcine graft on. An isograft is someone that comes from your twin or your triplet. So genetically, they're virtually identical to you. But skin taken from one species to another, like pig skin, for instance, is a xenograft. And we do use them. It's not unusual. Like any wound, as you guys know, you've got to have an optimal wound bed. You've got to do your wound bed preparation. You've got to make sure that how you prepare it, either by dressings or by debridement or by negative wound pressure therapy, that wound has to be clean. And one of the biggest problems that we have at the Royal London is pseudomonal infections. We go through, they're like buses, they come along every so often, and you'll have a whole group of patients colonised with Pseudomonas, or even worse than that, hemolytic streptococcal infections. And with hemolytic strep, we can't graft those wounds because as soon as we take the skin on, the skin will be destroyed with the infection. So we tend to have to take frequent wound swabs, get the wound bed ready, or once it's clean and ready for grafting, that patient can go off and be grafted. And so sometimes we will actually send people home either with a disposable negative wound pressure like a PICO, or to the district nurses with traditional wound care dressings, and they will then come back into us as a day case if need be and be grafted and then sent home again the same day. And obviously an ideal wound bed is free from infection and has no visible dead tissue there at all. It's not uncommon sometimes for patients to come back 5 or 6 days later, or having a graft check 5 or 6 days later, and you take the dressings off and the skin graft comes off. It's because the wound bed hasn't been debrided properly, or they've come down with an infection. A lot of the times is you get some areas where the wound bed hasn't been debrided sufficiently for the skin graft to take. And we can't graft cartilage, we can't graft bone or tendon due to its limited blood supply. So with those kind of areas, you're looking at either full thickness grafts or free or local tissue transfer, which is basically flaps. So again, those are areas we can't deal with. The process of graft take, it's usually by a method of diffusion where nutrients like fibrin go from the wound bed into the graft, and what it actually does is hooks onto the skin graft itself and actually starts to pull it down onto the wound bed So in a perverse way, the skin graft actually starts to put weight on, and it keeps that skin graft alive for around about 3 to 5 days before the blood supply starts to come up and start nourishing the graft itself. So we can do an early skin graft check in, say, 3 days, but we tend to leave skin grafts alone for around about 5, sometimes 7 days, depending on the wound, depending on its location, and depending on that patient. And really, skin graft take is an angiogenic process. And it still remodels itself 12 to 18 months down the line. So in fact, what you see now, in a year, it will probably shrink around about 10% of its original size. So you'll see a little bit of shrinking, a little bit of the cavity filling up a little bit. So you don't necessarily get that concave effect. You'll probably just get a smaller little defect. And the problem is later on, when these grafts start to remodel, like anything with scars, there's typical problems of itching, of going out in strong sunlight. We always recommend that you use the high factor suntan lotions like the factor 50s for your skin grafts and your donor sites. And of course, when you take a piece of skin, what the patients don't realise is that you've destroyed the sweat glands where you've taken the skin graft from. So the area, the recipient where the skin graft is going to go, will not sweat again. And therefore, they get a lot of itching as the nerve endings are trying to sort themselves out, but also because there are no sweat glands there. And so massaging and moisturising that for the first 12 to 18 months is very, very important. And of course, people they want to scratch. And we ask them, try desperately not to. And sometimes the best way is just to get them to tap that area and then carry on moisturising it, or take things like antihistamine drugs to try and help solve it down a little bit. So although we might be skin grafting and we think that wound is healed, it still takes another year, possibly 18 months for it to actually settle down before we can actually say, yes, that's completely healed now. And what you've got now is what you're going to get for the rest of your life. So you do still end up with scarring to a certain degree, but the scarring with the skin graft is a lot better than it would be if some of these wounds were left to heal by their own intention. So, top picture, as you can see, is a freshly cropped piece of skin, the donor site there. Nowadays we use electric dermatomes. In the olden days it used to be a block of wood stuck against your thigh and then a Watson blade, and you would shave across and take the skin that way. Isn't it amazing after 30 years how things have changed? It's like, it's just like that going to the hairdressers or going to the barbers and getting your hair cut. So it's much more quicker. Is it any better? I don't know, actually. I don't know whether the old days with a blade and a block of wood or electric dermatomes any better. I think from a surgeon's point of view, yes, it is, because it's obviously a lot quicker than what it used to be. Most plastic surgery units will use an alginate dressing to cover over. There is a lot of those who've been out to Australia and New Zealand where they will use things like MeFix or Hyperfix and put that over a donor site and carry on putting it over and over and over until you get several layers up. I mean, I don't think there's a lot of evidence to say that's any better than using an alginate or hemostatic dressing than using that. I think the jury's out on that, really. So this gentleman was actually in a road traffic accident, was brought to the Royal London. Thankfully, there was no fractures on his lower limb. So in fact, this was debrided quite quickly. In fact, he was actually had a car tyre run over him, so he had partial degloving there. So that was all debrided back down prior to the skin graft being put on. And as you can see, that wound is now clean. It's been debrided right down to clean, healthy tissue. And that's the graft on. Now, the holes in this graft are called fenestrations. We don't always put sheet skin on people. The only time you would see someone with sheet skin on their body is on their face. It's been a few years since I've actually put a skin graft on somebody. Unfortunately, the Human Tissue Act has stopped us from actually, as nurses, as plastic surgery nurses, putting skin grafts on, unless the institutions that we work for have secure storage facilities. We at Whitechapel don't have that. So in the olden days, you could take a piece of skin, put it in the fridge, a designated skin fridge for 3 weeks, and then, you know, you could put the skin graft on in the first 2 weeks, and if that took, well, hey presto, and if it didn't, well, you could use it as a dressing. So by having those holes in it, it allows all the, the yellow lights come up, all the serous fluid and hemoserous fluid to actually come through that graft. If we didn't do that, what would happen is all this hemoserous fluid and small hematomas would mechanically lift that graft off, and that graft would then fail. Donor sites, this one healed quite rapidly after 14 days. You can still see where on the bottom of the leg it's still quite dry and scabby. Again, this is where your moisturising comes through. And it's always the donor site that people complain of. It's always the donor site. It's like having a very, very deep graze, stinging like mad. Again, the top piece of skin was just fenestrated with a blade by hand. The one on the second picture was put through a mesher, so it goes on a special carrier and goes through a meshing machine, and that will then mesh the skin. You can mesh it from 3:1, 6:1, or 12:1. So by actually meshing it, you increase the area of the skin graft itself without having to take too much skin. This gentleman had a saphenous vein graft broken down. He was grafted. 4 weeks later, that looks pretty good. And he was quite happy. Again, we deal with a lot of lower limb trauma, so this gentleman here has got an external fixator on. That's 3 months down the line, and that's looking quite nice. You will see sometimes in the winter these grafts will change colour. They'll go a dark purple motley colour, and it's just basically telling the body that I'm cold. Common graft failure themes, well, it's really like any kind of wound, really. Infection, poor wound bed preparation, radiotherapy, smoking. It's amazing how many people out there who smoke don't realise that it can actually harm their wounds. And one of the problems that we get in Whitechapel is poor compliance. We have a real problem with people with what I can only describe as very busy lifestyles. Post-operative care, right, they can be painful. Donor sites, again, 3 weeks. We can usually adequately moisturise them 2 or 3 times a day once their healing is healed. With the donor site, the exit date usually peaks within 2 or 3 days. You can expect some small breakdowns if you've got the elderly patient or those that are immunocompromised. Problems, right, would you consider antimicrobial dressings, negative wound pressure, antibiotic cover, or actually will we bring that patient back to theatre and actually debride their wounds and start again? Pseudomonas is a common problem. It just makes the graft very wet on appearance. Sometimes they don't stick down very well and they can smell. This chap we saw a couple of weeks ago, an intravenous drug abuser, large ulcers, was grafted, decided not to come back. 6 weeks later comes back. He's non-compliant with his treatment, so the decision was taken to put a negative wound pressure dressing on and let him go. We haven't seen him since. Overgranulated tissue, that's a problem we get, particularly with negative wound pressure over skin grafts. And conclusion, well, we have a very, I'll say this, we have a very, very good working relationship with the tissue viability teams in East London. So we will talk to them before we discharge anybody out into the community. And we need to have a really good level of communication, because sometimes what we see in hospital is what the community TVNs don't see, and vice versa. And so we need to let them know that there is a patient coming. We will send pictures via NHS mail, so it's all safe and provided. Again, for us in plastic surgery, good wound care knowledge, and as you know, there's hundreds of dressings out there on the market, and it's having not necessarily the right dressing. Sometimes we leave them exposed, sometimes it really depends on the patient. But for the most important thing for us here is if you have any problems or you have any doubts, please contact us at your local plastic surgery centre. All the plastic surgery centres in England will have a clinical nurse specialist of some sort, or a lead nurse or a specialist nurse. Contact them if you have problems. I know certainly from my point of view in East London, if there is an issue, tell us, we will bring that patient back in. And that's it. Thank you.
Thank you very much, Darren. Any questions? Yep. Oh.
Do I have to touch it? Okay. Hi, Darren.
Hello,
Alison from Accelerate. It was a comment on the common themes of failure, and I wondered on your views of edema in the lower limb.
Yeah.
And one of the things we found working with obviously one of your team, pre and post-op, is getting compression right before the op.
I absolutely agree with you.
And then getting it right on immediately.
Yeah.
And those things have really improved the success rate of lower limb grafting.
I think,
whether it's trauma or
I think you're absolutely right. There are some people out there who still think compression is not quite right. I certainly will compress those legs, and if they're skin graft or a flap, free flap, pedicle flap, island flap, whatever, I will say to them, right, well, you're 5-6 days down the line. If you're going to start mobilising these people, you need to start compression. There is one thing that I will add on to that is bandaging. Now, I've been around the block a few times myself, but when you see some people's bandaging, it defies logic. You have a wound that big with a bandage like that, but you're not supporting the whole of the lower limb, and particularly with lower limb trauma and skin graft. I mean, I agree with you. I would like to get, and I do often get them into compression straight away before we send them out. And there is another theme on that as well. We are a little bit selfish in plastics, where we take a lot of ownership of wounds, and it's not because we don't trust anybody else out there, but sometimes we've had to think outside of the box ourselves to treat these wounds, but also sometimes a lot of these patients want to come back before they go back to their district nurses or their TVNs out in the community, and that's where that communication comes in. But certainly, I mean, I would get them into compression straight away. As soon as we can, I would do. And it is amazing, like you say, when you start getting them into compression, you get that little peak of exudate and edema, and then all of a sudden it just goes. And I think, if we can just get over that little period, absolutely. I would be a champion of that.
Any other questions?
You ready? Oh, blimey.
Can I ask you what you use for overgranulation, please?
It depends. I mean, sometimes we use something like Fusibet. We do have silver nitrate. We can use that if necessary. It really depends on who's seeing that wound. I mean, the surgeons, if you give them a stick of silver nitrate, well, that's it. They'll paint they'll paint everything with it. I think that there is some use for it. There has its uses, but I think you have to be very careful how you're using it, because not all areas of overgranulation are painless. And so I think something like the first choice at the Royal London is something like Fusibet. I mean, I do know there are other areas in London that have gone back to using terracortial. But that's their choice. If that's their ways of doing it, that's entirely up to them. But if it's something that's very, very small, a little bit of silver nitrate, if not, something like Fusibet. It's not very often that we see that, actually. I mean, sometimes we get a bit as a byproduct of negative wound pressure, and it's possibly because the negative wound pressure has been on a tad too long. Because we at the London are now trying to graft with negative wound pressure. If you're an inpatient and after 3 days the pump comes off, the dressing comes down, it's a conventional dressing. But we have now gone more and more down the line of day case surgery for skin grafting, and using something disposable and sending people home and then bringing them back in 5 days. Because again, we don't have the luxury of keeping people in with some of these wounds.
Okay, that's lovely. Thank you.
Right,
Thanks
thank you very
Darren.
much. Thank you.